Hello everyone, this is Bart Modrzynski from CTI Data. It will be my pleasure to take you on a short journey how data can be leveraged to improve clinical outcomes and patient safety. I will demonstrate our active intelligence real-time patient surveillance solution and will show you how Click Analytics can deliver real-time patient risk assessments and alerts with preemptive interventions, integrating multiple early warning systems and industry standard models like SOFA or LDT News, and then walk you through a process of exploration and discovering relevant patient data in many electronic healthcare system records, and how to integrate and harness all that data from EHR into a cloud-based data storage and solution in real time, powering analytics, and at the end, walk you through an end-to-end CTI Fabric-based governance model that delivers searchable and trustworthy data. We use real-world evidence, leveraged Mimic4, developed and maintained by Physinet.org and MIT. Data is collected from real hospital stays and patient admits for over 40,000 patients in many academic medical centers in Boston. It includes patient chart data, lab measurements, medications, vital signs, documentation, death records, social determinants of health, and others. Data is fully de-identified. We abstracted data from source EHR structures like Epic, Allscripts, and Cerner for ease of use and demonstration. However, we have hooks and connections, and we have a model that understands all major EHR systems, scheduling platforms, bedside monitoring, and real data streaming. So let me set the stage for what we'll be showing you and what's under the hood of our solution. I'm going to use some medical nomenclature that is relevant and will be important for medical staff and the consumers. In our example, we've created a dynamic patient acuity score using our model of models. It pulls together 3 commonly used and validated early warning systems. But any number of EWS scores or other scoring methods can be integrated into our framework. So again, in our example, the 3 patient scoring models are the National Early Warning System, NEWS, which is based on 6 vital signs, Lab Decision Tree Early Warning Score, LDT EWS, which scores acuity based on 7 lab test results, and Sequential Organ Failure SOFA score, which is based on 6 variables used to track a person's status during the stay in an ICU to determine the extent of person's organ function or rate of failure, and is based on 6 different scores, 1 each for the respiratory, cardio, hepatic, coagulation, renal, and neurological systems. We created a data pipeline that takes real live healthcare data, scores by model, and we apply our data engineering and data science to create a model of models to predict mortality risk and guide earliest intervention. So we designed the app for average user, non-technical savvy. So imagine someone in a hospital setting, a chief nursing officer or a business analyst. And what I'm going to do, I'm going to open it up on my PC web browser, but it works on any device that you can potentially imagine. So let me click that hyperlink, and immediately it brings up the hospital unit board's outcome dashboards for you. Imagine you're a CMO or head of quality or patient services and want to understand the dynamics and why certain patient outcomes occur, and if negative, how could we improve? First, I want to see a big picture for my hospital's units, admissions, and stay. So what you see here is the hospital dashboard for patients that got admitted and stayed in the hospital within the last several days and today. I have patients in the observation admit, 380 patients, patients in elective, emergency ward, 185 patients urgent, same day, direct emergency, and others. So on top of that, we overlaid a patient outcome, and we group them into certain categories that might be meaningful
So for example, with patients in observations, 128 got discharged home or about to discharge home, 115 home healthcare, 62 SNF, 12 long-term, and that pattern occurs across all of the admission settings. So for example, I can drill down and take a deeper look into direct emergency. One patient died, 8 got discharged home. So that builds me some confidence on where those patients end up from an admission and outcomes perspective. So what concerns me a little bit is the number of patients that died. As far as the urgent 13, I can justify perhaps that's something that's been before and I can do things or not. But what's really concerning is the mortality within the observation, right? 21 patients, out of which 20 died in the hospital. So let's examine that and let's start looking at the predictors.
So in the prior step, we identify the negative outcome to understand better. In this case, it is patient mortality, highlighted in red here. You can see 53 patients died in our hospital setting. Other outcomes are grayed out, but I can always click and examine them in the same way. So the first thing I want to do is to understand the factors that contribute to patients' mortality in our hospital. And the first variable I'm going to look at is just the hospital setting. So I can see that out of the observation admissions, 21 patients died. Out of urgent, a little bit less, 13, and out of emergency ward, 15. The rest is negligible. So now, let me add another variable, baseline variable, to understand where those patients came from. So in this setting, I'm gonna use Qlik's drag and drop feature and just bring a admitted from variable and move it to the beginning. So what it shows me now, what was the origination of patients that eventually died. I can see that the majority of patients that came to an urgent unit came from transfer from our other hospital. So that's worth mentioning why. I can also see that some of the observation admits that ended up in mortality came from physician referrals in this case, for example. And the rest was pretty much equally spread through emergency room, walk-in referrals, etc. So there is no conclusion, and it can't be. That's not enough to determine, right? There is too much stuff going on. I could examine how many that some of my transfers from other hospital to urgent ended up in mortality, but I need more. I need more variables, right? Because someone might say, well, we have conditions that patient got admitted to. We are DRG groups. We have all sorts of vitals and labs, and I could the same way add these variables to the mix. However, this would make this whole view very complicated or almost impossible for a human being to examine every single combination of variables, clinical, labs, medications, social determinants of health, and others in conjunction with the hospital operations. This is too hard, so that's why we employed machine learning and we built a model that takes all these factors and pushes it down to calculate and build coefficients and better highlight the predictors that contribute to the fact that patients died or their health deteriorated in one way or the other. So our model scored individual patients and cases. So let me now focus on the observation settings. Click on it and drill down to see the next screen. I can see here all my patients admitted for observation and their EHR and clinical data, including admissions, transfers, diagnosis, patient chart, bedside monitoring, streaming, labs, meds, vitals, and others. Medical record number, so each line represents a patient, gender, age, admission or transfer data, date of admission. One note here, data is fully de-identified, so even though these years are random, data is consistently clinically correlated within each patient. Diagnosis-related group, past ER visits that got calculated, ICD codes, clinical codes associated with patient. And then
a lot of detailed data from lab LMS systems, hemoglobin, oxygen saturation, respiration indicators, tons of different columns that I won't be showing him in detail. And these are just the latest and greatest results from current minute, current hour. Now, imagine someone analyzing the data. It becomes almost impossible to do. And that's why I'm going to show you how our model simplifies things. Let me activate here our AI early warning system. And that brings back our model calculated data in real time. What I can see here is the LDT news scoring, sequential organ failure score, our mortality risk model that takes into account all these scores and individual variables from patient chart, comorbidity calculation, and pre-calculated readmission rate. Each of the models has its own system of alerts for interventions. So as medical staff or chief nursing officer, a doctor, I can examine a list of my patients in the unit, and my attention is drawn to those of high risk. And at the same time, I can see that the news score is actually increasing, and that's important. It's not only a number, but a rate of change. And in some cases, SOFA score kicks in, which means something's really bad is happening to this patient. So how does it work? Let me focus on patients only about 55 years of age, for example, and of those that are really high risk of mortality. So in this case, I see a patient with 88%, also SOFA score, and very rapidly increasing HDT news. So let's examine that patient. Now I'm in the patient view. So I have all the baseline and demographics information about the patient. I have the diagnosis, associated disease codes, and the history of development, along with the comorbidity and LACE score, and then predictions about the length of stay. The model tries to predict the length of stay at the beginning of the admission, but then things change. So we have early and predicted late discharge. Now, what's really important here is the three models we talked about. What we do here, we overlay them on a timeline, which means we're not only looking and calculating the latest score, but we do it at every single point in time where the labs, meds, and other patient charts data comes in. And we draw conclusions based on these points. So as you can see, there is a progression of patient disease or patient state developing over time, where at each point, these labs are traceable, taken. And as you can see, at certain point for that patient, the score goes really high, right? There's something's going on in here. And our linear regression model predicts that too. You can also see the SOFA score gets worse at certain point in time, so there is something else going on. And on top of that, our CTI mortality risk model predicts at every single point what's the ratio, what's the risk of patient ended up dying, and that model deteriorates and shows the high scores as well. So at any point in time here, before the outcome happens, you as a consumer, you as a doctor, you can start taking actions, drill in, and see what are the details, what are the labs, what are the critical modifiable variables that you can take and intervene to save the patient.
We're looking at the early warning system. So although historically you can see past data and scores taken in every single moment in time, in reality, as a doctor or as medical staff, I'll be somewhere here. So let me focus on that moment in time where SOFA scores were not really that high yet. However, at the same time, our early warning system risk model indicated a rapidly increasing risk of patients' mortality. So this is extremely important because that trigger can alert a staff member or a doctor or someone on ICU to really intervene before patient deterioration and the condition will get much worse, which leads to potential patient death.
If you're interested in the details, how the model got built and the process we went through, we'll have a follow-up session or Q&A with you, and feel free to sign up with our chief data scientist and the team, how they arrived with the model across the process with unsupervised learning, with variations, predictor selections. I have a simplified data frame here, which shows some of that scoring mechanism, how it gets passed back with the click and back in Python and R programming. So that's not covered in this presentation, but we'll be happy to walk you through some of the details live. For the use cases built, data was very complex and requires a thoughtful methodical approach in data engineering. And that's what we do at CTI. In reality, we had to connect to fragmented systems and tables across, for example, person, org, personnel, encounters, clinical data from large clinical event tables in real time, feature appointments, ingest glucose monitoring and streaming data, or even death records from public payers. I will demonstrate how to connect and extract data from EHR using QDI replication with Qlik, organize data in Snowflake for analytics and AI. So I log on to my replicate tool and have a number of tasks. Let me open one of the tasks that we created for this demo. So I configured here a connection to our EHR system. And the target is Snowflake, as I showed you in the cloud. In this case, AWS, could be Azure. What I'm going to do now is to quickly select tables that I want to add. As you can see, we already have an encounter table. What I'm going to do now is add additional data points. So this is a schema. I can pick and select any schema I'd like and look for specific tables. In this case, I'm looking for something that has something to do with person. So that's very easy. I don't have to know a specific table name. I'm just connecting to table person and personnel. Perhaps these two I would like to replicate. And all I have to do is click OK and run the task. As you can see, data is being loaded in real time. There is a number of records loading, completed, and fulfilled for these additional tables, right? So that's a great place for someone that watches the data processing to be able to review it in real time. I'm going to show you real quick how you can change some advanced settings to tune the loads, right? So this is for admins, developers. There is a way to custom transform data on a load. And this is what our engineering team does. We really focus on the meaning of data and how data should be organized, orchestrated over load. So, rather than just bare hand coding in SQL, those types of settings and transforms and functions speed up development and let us focus on what's really important. Filters, parallel loads, and others. There is also ability to set up tasks to change processing in real time, store things in a different place, set the naming conventions. So all the goodies that offload your team from doing very rudimentary work. And finally, I'm gonna set the resume processing to have this task running. So in this case, the change data capture is tuned into any changes in EHR. We don't have to manually run it. It will just wait till new data arrives and will automatically push it through up to Snowflake.
So now, how do we harness the complexities of electronic health records, models, and data to produce that nice and comprehensive picture? In this step, I'm going to get the lay of the land of my source, EHR data,
With the Qlik Compose, I can engineer a new model, discover and explore an existing system, or import from another modeling tool like Erwin. Earlier in the demo, I replicated my Cerner data into our data lake. I will use Discovery to make sense out of the data with the help of Auto Reverse Engineering tool. I can simply throw in all my source data and have the Discovery tool figure it out for me. In this case, I want to be more selective and focus on the tables needed for the model, like encounter, org, or person and specialty. And the model gets generated automatically within the context of selected data. They say a picture is worth 1,000 words. And I agree. And that's so true in data architecture. So the constructed model allows me to see my key entities, relationships, key characteristics, and attributes. Augmenting the data, adding new data definition is just a few clicks steps away. So well armed with the knowledge and critical understanding of my medical records data, and with the model on my doorstep, I'm ready to build my hub, data lake, or a data warehouse of a choice. Although the data warehouse is generated, it is prudent to check the outcome, validate, and tweak where necessary. The encounter data flow gives me a chance to examine how my patient admission row data got translated into user-friendly and governed terms. For example, admission dates, admission months, etc. With a modern data architecture, I can have my patient grid, context, and the surveillance chart engineered here. I can construct the data frame with the LDT and SOFA binary flags for data science consumption. The outcome of our engineered journey is a fine-tuned data mart, collection of data sets or subject areas. Star schemas, aggregates, dimensions, measures are ready for the end user consumption. From that point, any BI reporting, analytical, or data science tools can be used to deliver data. In our demo, we leverage ClickSense, which gives additional benefits while integrated with the engineered model. And as we're nearing the end of the presentation, I'd like to step back a little bit and from the use case and the specific data application into a more broader picture, how a sustainable and proper fabric-driven architecture could look like. And I'd really love to discuss with you. I know it's a separate topic, so I'll be happy to discuss that with your team, and we'll provide a link to the invitation towards the end of the slide. But in a brief overview, I just wanted to point you to very time to value driven accelerated approach the architecture provides through continuous and unified data exploration, integration, grassroots data governance with supporting top-down and bottom-up models with frictionless data acquisitions, onboarding, curation, and decommissioning process, where we employed our CTI originated data zones or logical regions that allow for separation and data classification depending on the audience and consumer. With data prep capabilities and augmentation of data, machine learning to facilitate adjustment of the data fabric and discovery of automatic data models. Let's work together. Visit us at ctidata.com. The link to the full invitation will be at the end of the presentation. I'd love to invite you to our virtual meeting with your team, where our healthcare experts, data scientists, data engineer will help you to develop a strategy, how to use tools and platforms, as well as modern data architecture
to accelerate on your healthcare innovation and delivery with data. Thank you very much for your time.